You're hot because you're watching Rafi Boritzer, Boritzer's Bio Briefings. And the reason we are not hot is because we don't have a temperature. We have a doctor in the house. Our guest today, right here on Think Tech Television's Boritzer's Bio Briefings, is Dr. Dan Davis. Welcome aboard, Dan.
Hey, Rafi. Good to see you.
Dr. Davis is a clinical informatics professor, a clinical professor at Queen's Hospital Medical School of UH, and is also a specialist and expert, how would I say, the father of modern informatics right here in Hawaii, as well as other places. And we're going to be discussing the revolution in healthcare. Now just think about what happens when you need to go to the doctor's office. Think of the reason you want to go to the doctor's office. What is the most common reason that people come to see you, Dan?
Probably the most common reason is colds, upper respiratory tract infections.
So they got up in the morning, they have a slight sore throat, either they want to stay in bed, either it's a terrible weather day outside and they don't want to wait at the bus station, or they decide they need a day off from work and they need a slip or not to go to school.
Yep.
So this is the first inkling that they may have a legitimate, valid excuse.
Correct.
Correct.
Yeah. So they come to the doctor's office. And
you're the validator in chief.
That's correct.
I mean, at the end of the day, they're not going to the dispatcher for the bus to get a note from him that the bus didn't work, but they're going to come to you for a doctor's note, either for work or other reasons.
Yep.
Now, what would you say is the percentage of those kind of cases?
If you look at acute self-limited illnesses, colds, gastroenteritis, those kinds of things, probably about 20 to 30%.
My God, that's all. So if we're looking at an 8-hour day that you put in, I know you put in more hours than 8 hours, but if you put in an 8-hour day, and it would take 20% of that.
Yeah, 2, 3, sometimes 4 patients a day.
4 patients a day. Now, if we start just looking at the macroeconomics of this, it's just tremendous in terms of the cost to society. Of just doing this kind of work. This is like the most basic. We're not talking about cancer care. We're not talking about pneumonia treatment. We're not talking about an auto accident. We're talking about something that is perhaps will in and of itself fix those problems with rest and proper diet regimen, or perhaps exercise, or perhaps some kind of supplements would have taken care of it or prevented it in the first place, perhaps protection from infection. Yeah. And so on.
Yeah, you're right. The bucket of illnesses that we describe are acute self-limited illnesses, and for decades people have been accustomed to coming to the doctor's office to get evaluated and treated for conditions that often will go away by themselves. If you look at what I call the value-added steps in the care process, what you find is that a lot of those steps actually really don't lead to improved outcomes. And that's where the idea of telemedicine comes in, because many of these acute self-limited illnesses can be managed through teletechnologies. And it's far more convenient and probably less costly for people to get care through that kind of telemedicine. That's what I call convenience telemedicine.
I'm glad you brought that up, because permit me for a second to backtrack a tiny bit and go to the word outcomes. Because I think that's where the horse is buried, or where the dog is buried, to use an old expression. I don't know if it translates well into English, but that's where the dog is buried. The outcomes. We use it in almost any kind of professional services that we go shopping for, or that society is giving us or selling to us. What are the outcomes? What are the outcomes in the patient's health? What are the outcomes in student learning? What are the outcomes in satisfaction from products and services do we have? And let me ask you, what is the typical outcome that the patient expects from you?
Well, that's a very broad question, but in general, they expect comfort. They expect reassurance. They expect scientific accuracy. They expect us not to make mistakes in a diagnosis or treatment. And they expect to feel better sooner or later after that intervention.
So that feel good is a very important component.
Yeah.
Now, is there a differentiation in the age groups or the level of illness that it measures this kind of satisfaction? Do we have differentials in terms of ages, first of all?
Well, we certainly have a difference in age relative to what kind of problems people come to the doctor for. For example, healthy 25-year-old male typically will not come to the doctor's office for any serious illnesses. Most of them are healthy. They come in for an acute self-limited illness. Again, upper respiratory tract infection, acute bronchitis, gastroenteritis, maybe some low back pain, something like that. So that's a lot different than a 75-year-old who comes to the office more often for cardiovascular disease, cancer management, high blood pressure, those sorts of things.
I know you do these things every day and been doing them for many years, and so it seems to you like very common, but as a patient to the doctor's office, it's a unique experience, again, depending on the age group, how often you come, for how severe a condition you're coming from. So, as you said, if you have an acute situation of a young male or female, they expect you to take care of it in some very dramatic ways, perhaps. Whereas for an older patient, I'm thinking more of the above 50 or pre-geriatric or geriatric patient, they're not coming for that. They know you're not going to fix their diabetes or their dementia or their OCPD. They're coming for something else. And the reason I'm going there, because we're going to be talking about telemedicine, and I think this is one of the differentiating aspects of in-office care and telemedicine that I want to get into, and how you overcome some of the bridges or obstacles in providing the same level of comfort care or whatever is necessary. So tell me a little bit about the post-50 patients when they come to your office. What do they want really from you, because apparently they're coming often for conditions that already are pre-existing?
Yeah, I think that the older patients perhaps put more emphasis on the comfort and the reassurance and needing to have confidence in the doctor-patient relationship. I think they're more dependent on that, perhaps, than the younger patient who's really just wanting to get an immediate problem solved. That perhaps is the biggest difference that I observe. So the interpersonal relationship, the doctor-patient relationship, or it could be a nurse-patient relationship, depending on who the primary caregiver is. And I'm speaking mostly in primary care environment right now. That emotional bonding, confidence relationship is really important for the older patients.
How about the traditional Hawaiian problem-solving methodology of talk story? What role is that play? And again, because I think that's one of those areas that we'll talk about transferring to telemedicine, how does that figure into the paradigm of services that is expected to be?
Well, it's really important. I mean, if a patient has a problem that they're really worried about and you don't talk to the patient, then that can present problems, because you're not using the therapeutic relationship as a tool of therapy. And that relationship between the doctor and the patient is extremely important. And in order to do that, you've got to listen to the patient, you've got to interact with the patient, talk to the patient. And the fact of the matter is that telemedicine, when properly applied, really enhances that relationship. For example, in some of my medically fragile patients, the ability to be talking to the doctor within literally minutes, knowing that the doctor's looking at me, the patient, within a matter of minutes, typically 2 or 3 minutes of a telephone call, that provides an enormous amount of reassurance for patients who are chronically ill, who are perhaps acutely ill for the rest of their lives, who have really serious medical problems. So using the technology to leverage that relationship is really important. But it's like any other tool. If it's misused and the telemedicine technology is not used to enhance that relationship, or if that relationship doesn't exist to begin with, then you probably have not as successful results from the telemedicine interaction. You know, and that's important. The more serious the problems are, the more important that kind of relationship is. The more chronic the problems are, the more important that relationship is. On the other end of the spectrum, one end of the spectrum being medically fragile patients, on the other end of the spectrum where you're talking about convenience telemedicine, the first patient we described, in that situation, basically they want to know whether they have a cold or they have pneumonia, whether they need an antibiotic or not, or let's take the example of a 28-year-old single mom who has 2 kids that are toddlers, preschool age, who develops a urinary tract infection on a Friday night. Her interest is being able to get her urinary tract infection treated right away in a convenient way that takes into account the fact that she's got 2 toddlers in bed at 9 o'clock who are sleeping. She doesn't want to have to get them out of bed, get them dressed, take them down to the urgent care facility or the emergency department, wait 6 hours, see the doc for 5 minutes, and then have to go to the pharmacy for an antibiotic. What she's interested in is getting that problem diagnosed immediately, conveniently, with as minimal disruption in her family situation as possible. And at least in the vision that I have in the world is to have her antibiotic delivered to her home just as quickly as you can get a pizza delivered. That, to me, and doing that all over telemedicine so that she doesn't have to leave home, that to me is what a lot of these patients need and want in terms of convenience and immediate access to care. And if you contrast that to a conventional care model where people have to get up, get dressed, get the kids dressed, all that sort of stuff, go to the doctor's office or go to some clinic someplace, wait to be seen, get the diagnosis made, and then go to the pharmacy and wait for the pharmacy to put their medications together and then go home. To me, it's like orders of magnitude better to try to build a telemedicine environment that provides that kind of efficient care.
Before we jump into all kinds of areas that I want to ask you about, let's describe a little bit the telemedicine structure, if you don't mind, just the physical structure. So why don't we look at our first slide, if you don't mind. Okay, and I believe that this was okay, where you kind of describe what is telemedicine.
Yeah, fundamentally, what telemedicine is, it's delivering healthcare over distance and time, and it's using communication technologies to do that. They might be video technologies, they might be a smartphone, it might be remote patient monitoring, a variety of different modalities, but fundamentally it's delivering healthcare over distance and time. And by distance I mean the distance barriers of a medically fragile patient getting from their home in Hawaii Kai down to the doctor's office here downtown. That's a huge distance. They might as well be on the Big Island, particularly if they're on a home ventilator or have multiple complications. Or that mother that I was describing, Friday night, probable bladder infection, 2 kids, and no other support. I mean, for her to overcome the distance from her home to some treatment facility, that's a huge barrier. Time-wise, being able to evaluate a patient within 2 or 3 minutes of a problem developing really kind of leaps those barriers of time. So delivering healthcare, overcoming the distance barriers and time barriers using these teletechnologies is what telemedicine really is.
So what I see right away, a multiplier effect. It's like the whole model of the industrial society after the horse and buggy and the farm societies, that you constantly leverage your time and your skills over several people within a much shorter time frame than traveling to each place or each one coming to you.
Correct.
Basically.
Absolutely.
Because the travel is eliminated. And for those of us who've sat on the H1 at 6 o'clock in the morning trying to get into town by 8 o'clock to get to the office, that's wasted time.
Yeah, you're right. So, I was kind of using this analogy of the different steps in the care process before. What telemedicine can do is allow us to eliminate those steps in the conventional care process that really don't add any value to the outcomes for the patient. I mean, what that mom wants is she wants her bladder infection treated right now with minimal hassle. And in the conventional care process, there are a lot of steps involved in there that really don't add value to achieving those outcomes. And again, that's what telemedicine does.
You're watching our show, and Boritzer's Bio Briefings. My guest today is Dan Davis, expert extraordinaire in video technology, in the use of medicine, especially in informatics, which Dr. Davis has developed right here in Hawaii. And we think that we are somewhere in the middle of the Pacific, but with video conferencing and telemedicine, we're going to be right in your living room, in your bedroom, or any place else that you let us in.
Only with permission.
With permission. So we're going to take a little break. Until we come back, you've been watching Boritzer's Bio Briefings. We'll be right back to you. You're hot because you're watching Boritzer's Bio Briefings. We are not. We're here waiting to get your phone calls, your comments, and your attention to what's going on right here in the studio. We have Dr. Dan Davis, expert extraordinaire in medical informatics and telemedicine, and he wants to continue explaining to us exactly the structure of telemedicine, the way he set it up.
Yeah, so two additional points about the structure of telemedicine. There's this notion that to the extent that we can change atoms to bits, that will be far ahead in the delivery of healthcare through telemedicine. And by atoms to bits, what we're referring to is taking the sort of the physical interaction that happens, maybe a face-to-face visit, or someone having to physically go from their home down to the doctor's office. That's the atoms moving down the congested freeway at 6 in the morning to the doctor's office. If we can turn that into bits, data bits, that we can transmit over telecommunication, then we can eliminate all of those steps that really don't add anything at all to taking better care of the patients. And not everything in healthcare can be done that way, but a lot of stuff can. And that's what we're beginning to attack with telemedicine, is changing the healthcare process from atoms to bits, where we can move knowledge from the place where it happens to be at one point, the expert, the doctor, the nurse, to right where the patient happens to be, out at their home or their office or some other physical location. That's atoms to bits. Okay. Okay.
Now you have brought a very interesting pictures that I find really something from the past.
Yeah. Yeah.
And I love. Why don't we show the second? There we go.
I love this slide. This is a picture of a magazine cover from, I believe it's 1924. Magazine called Radio News, and if you look in detail at that picture, what you see is a young boy sitting on the bed with his mouth open and his tongue out, and he's looking at a video monitor that shows the doctor looking at the doctor's video monitor, which shows the video of the patient, the young man. And there's an antenna on top of this device, and somehow or another these signals are getting transmitted over the ether, from point A to point B. That's telemedicine. That was the idea of telemedicine in 1924, and I believe the first actual television transmission didn't happen until about 1927 or 1929. Wow. So this notion of being able to treat patients over distance using communication technology has been around for a very long time. Telemedicine projects have been around since the late 70s, but telemedicine really hasn't taken off until the development of good video over the web. And so we have this old telemedicine, which was sort of the big iron, what I call the big iron telemedicine. Big monitors, very expensive computers, difficult to manage bandwidth, that sort of thing. And all that's shrunk down to you know, little bitty devices like this that run over broadband and our existing web. So virtually all of the new telemedicine is going to be web-based, and that's what we're using now in our telemedicine projects here in Hawaii. But the idea was captured in that slide, or that magazine cover, in 1924. And then there's a quote that I like from William Gibson, the science fiction author: "The future is here, it's just not evenly distributed." And the importance of that is that we have the technologies right now to do phenomenal web-based telemedicine. So the future is in fact here. It's just now the challenge is to figure out the organizational relationships about how we can do it, how we can get the entities to which the value accrues for telemedicine to actually pay for it. You know, in U.S. healthcare, getting things paid for is a tremendous step. So that's where we are right now, and we've got several very successful projects here in Hawaii, but we're thinking of new ways to add value to healthcare, but then the challenge is obviously figuring out how to pay for it.
Okay. You're right. You're going right along my path over here, the questions that I want to ask. So I'm coming into your office, as I've come many times before, and I've waited outside maybe anywhere from 15 minutes to half an hour, sometimes more, depending on the patient load and the emergencies and so on. How does that change for me if I call you up and I say I'm in for a routine medical examination?
Well, let's take the example of high blood pressure. Okay. Very common problem. Typically, in the conventional care model, the patient will come back to the doctor's office periodically and have their blood pressure checked, maybe have some laboratory tests done, maybe the doctor will listen to the heart, that sort of thing. Fairly simple visit, and then the patient leaves. Well, you get all that done after waiting for 45 minutes and 5 minutes with the doctor, so on and so forth. In a telemedicine world, the way that would change is you would log your blood pressures that you're checking at home. All right, you put them in your iPhone. Okay, you hit a little button to send that information to my website, and then my website looks at that information coming in, and as long as your average blood pressures are within target, you're happy, your iPhone's happy, the web server's happy, and I'm happy. All right, if you stop turning in your blood pressures after a certain period, the website, the server's not going to be happy, and it's going to let me know, and then I'm going to get in touch with you. Okay, and I monitor that stuff periodically. It's more like a continuous care rather than episodic care, and you may not have to come into the office but once a year for that, because if you're doing what you should as a patient, I see that your blood pressures are doing well. I may send you to the laboratory, the neighborhood DLS lab, and have your laboratory tests drawn. I may call you up and say, Rafi, good job. Your average blood pressure is 128/80. You tell me you're not having any target organ symptoms, and your lab looks great. Your LDL cholesterol is less than 70 or whatever we decide it needs to be. And keep doing what you're doing. I'll check back in next quarter. We do all that electronically. You never have to physically come to the office.
Now let me ask you another question. One of the things that I know that when I come to your office, you're always typing on the computer as I come and sit opposite you, and you're asking me questions which you previously would write down by longhand, and now it's done fairly quickly as you put it into the computer, depending on your speed of input. The question is, do you see a time when the patient themselves can put in some of their social behavior or a history instead? Because I don't want to say this, but everybody else is saying it. It's all about the money. Time is money. So if you want to reduce your healthcare costs to the patient or to his insurance provider, he's got to be participant, not just an observer or bystander. Do I have that correctly?
Let's go back to the model of managing your blood pressure. Okay. So if you take the responsibility of checking your blood pressures at home and logging them into your smartphone, then I am reassured that you're doing what you need to be doing. And I see those laboratory tests every 3 months or 6 months or whatever it happens to be, and I see that. I'm happy with that, but you've done a lot of the work to manage yourself. I'm looking at the data and saying, hey, keep it up, you're doing a great job.
So let me go to the next step.
Yeah.
So if you can measure my blood pressure or analyze the results, why can't I send to you also my weight? Why do I have to take my shoes off so you don't add my weight of my heavy shoes on the chart? Why can't I do that at home and have it by telemetry just sent the same way?
You could.
I could. So now let's go to the next step. So if I'm a pre-diabetic and you're concerned that I may turn to an A1C of above 7, why can't you measure my glucose without me going to the lab? I can take my own blood with a very simple prick. I know it's not as good as the complete blood analysis, but just for at the moment, because if you're looking at time, 0 plus 1 or T plus 1, you could do that at home as well.
That's correct. What you're describing is the notion of remote patient monitoring, and there are tools today that work really well for remote patient monitoring. Again, they can't do everything, but you know, blood pressure, weight, self-monitored blood glucoses,
urine, and
those kinds of things can be done easily and are done routinely in a small percentage of the population.
Okay.
So those things are available today. They're not used in as many people as they could be used, and quite honestly, I believe part of that has to do with the payment system, in the sense that most insurers do not pay for that kind of remote patient monitoring, and it does take clinician time to do that. The other problem is that not everybody is really reliable. Even if they have the tools available, they're not reliable in terms of checking their numbers. But that's the same as it would be if you were in a kind of a face-to-face conventional model too. I mean, the doc has to make some judgments about whether the blood pressures that a patient might be reporting in the office are really accurate.
Okay, so you say the tools do exist for the patient to do a lot of the work and not load up the system with routinized information.
Yeah.
Because if you are looking to do preventive medicine and also behavioral change, which happens to be my interest, there are other ways of doing it without having the patient trudge to the doctor's office, take up valuable time, and preempt people who really need care and diagnostic procedures and so on.
Yeah.
So I see the physician is actually a gateway to being almost a treatment director, has to create a treatment plan, an analysis, a diagnosis, and treatment plan, decide what is the best way to go with the minimum number of resources.
Yeah, I see a day in the very near future where patients with chronic medical conditions, again, let's use the common hypertension and diabetes, where in a medical practice, the doc will do just exactly that. They will sit down with the patient, perhaps on an annual basis, and say, let's formulate a plan for how you're going to care for yourself for the next year. Let's use these tools to enable you to do that. And so for patients who are good about monitoring their own numbers, and for patients who understand perhaps even how to change their medications within certain circumstances, those people are almost on autopilot and are being observed through the numbers by the doctor or the doctor's assistant periodically, and they can be on autopilot and go for a year and never really have to come into the doctor's office. Once a year, particularly for things like diabetes and hypertension, that sort of thing, the doctor needs to see them. But the point I'm making is that with today's tools, there's an enormous amount of good work that a motivated and informed patient can do to maintain their own health.
When we come back,
it's the teletechnology.
We're going to be looking at some of the tools, the network, the setup. What does it look like? Is it something out of a spacecraft? Is it something that you can do in the backwoods of Colorado or Idaho or Alaska? I know that you served a long time in Alaska as a bush doctor, if I may call it that, or an ice cap doctor.
Yes.
And so we'll be right back. You've been watching Boritzer's Bio Briefing. We'll be back right away with Dan Davis, our special guest today on telemedicine. Until then, stay tuned.
I'm Hong Jiang, host for Asia in Review on Tuesdays.
And I'm David Day,
host for Asian Review on Thursdays. Both of us broadcast our respective shows at 4 p.m.
And my topics tend to deal with questions related to environment, culture, history, and sometimes human rights.
And my shows tend to be on international business, foreign policy, geopolitics, and national security. And you can watch our shows live on the ThinkTech website at thinktechhawaii.com.
And you can also watch us on YouTube or Olalo.
So come join us on Thursdays at 4 p.m. I'm David Day.
And on Tuesdays at 4 p.m., I'm Hong Jiang.
Aloha.
Aloha.
So if I'm doing my own EKG, I can do it like that.
You're watching Boritzer's Bio Briefing right here out of Honolulu, Hawaii. My special guest today is Dan Davis, expert extraordinaire in telemedicine. And he's going to be checking out your heart rate, did you say? Right here?
Yeah, I'm going to show us a
us,
little
okay.
telemedicine EKG device. So I have my iPhone right here, and I can turn this little puppy on. And I'm going to open up an EKG app. This thing is called AliveCore. Okay. And it gives me instructions on the front of the screen about what to do. And I take my fingers and I just simply touch the pad on the back, and then it starts to give me an EKG. And I can actually look at this and see what my heart rhythm is doing. All right? And it'll collect information for about 15 seconds or so. And then once it's done, it will give me the option of emailing this to my doctor, okay? Or I can even send it off and get a paid EKG analysis for $1.
Wow.
Okay.
Wow.
Right there. So now, how am I going to use this in telemedicine? Well, for my heart patients, what I will probably do is just give them the device. If they have a smartphone, I'll just give them the device. They stick it on they download the app and they stick it on their phone. And then when they have palpitations, they just simply launch the app, do the EKG, and I can see what's going on. And it's sort of a cheap and easy ambulatory electrocardiogram. These things, if you're going to do it through the conventional way, it takes probably about 6 weeks to get the test ordered, and then people wear the device around for typically weeks, and then it takes a few weeks to get the results back. This way, I could give it to them right then in the office, and they can start recording whenever they want immediately.
Wait a second, Dan. Dan, one of the big thrills of getting an annual EKG, I must admit, this is very kinky. So please, if you have children in the room, please take them out of the room right now. One of the kinky things is that I like is the EKG coming in, the technician, and ripping off the sensors. What a thrill of pain.
Yeah, well, that's because your chest is too hairy.
Yeah, that's what my wife says all the time. Yes. Yeah. So I mean, that's gone with this device?
Well, yes and no. This is good for monitoring rhythms, but it's not a full diagnostic electrocardiogram.
Okay.
However, I believe in the future, near future, probably the next 3 to 5 years, we will have devices that'll do fully diagnostic EKGs in the home. The way I do EKGs in the home now for my medically fragile patients is I actually work with an organization that will take an EKG machine and a tech out into the home, put the little stickies on the chest and do an EKG for me, and then fax it into the office. So I can get an EKG fairly quickly, but it's not nearly as convenient as this.
But you're going to be able to see an arrhythmia if it's showing.
Oh yeah, yeah, absolutely. So I think there's a great utility for devices like this. Here's another one that is kind of interesting. This is a small video camera that can attach to a hat or a headband, and one can see what the individual's looking at. We use video to do what we call virtual coaching for our medically fragile patients. So a lot of these patients have tubes in their throat, a tracheostomy, a tube in the stomach called a gastrostomy, tubes other places in their body, and we often have to look closely at how these tubes are managed. And some of the caregivers don't have a lot of experience in doing these things, but with little cameras like this or the iCare exam cam, we can.
Oh, you mean this one right here next to you?
Yeah, this bigger one. This is a little bitty one that doesn't do pan, tilt, and zoom, This is a bigger one, and we actually have got more experience with this. It does pan-tilt zoom over the web in a highly secure fashion. So when one of our medically fragile patients has a problem, the caregiver, could be the patient or a family member or someone else who's at the bedside, calls us up and says, we've got this particular kind of problem, can you take a look at the patient? Within about 2 minutes of turning this thing on, and there's only one button that turns it on.
Oh my God.
The software,
I hope it's not watching me right now, please, please.
It's all software driven. This will connect wirelessly to our servers. The doc logs onto the secure servers and can see the video image coming through here, and it's extremely high quality. They can zoom all the way across the room, so from about 20 feet away, you can zoom in and look at a little mole or a skin lesion or what the tissue around the trach site looks like. We've got a slide in there if you want to see what kind of images come up.
Okay.
So we find this extremely useful.
Oh, you mean on slide number 4?
Yeah, the one that shows the camera and.
Oops.
Yeah.
Yeah. You see the one with the camera, yeah.
Yeah, so what this particular slide illustrates is the fact that we're able to see in great detail this particular patient's tracheostomy tube and make a diagnosis of what the problem is. We can also see the ventilator settings with the numbers going up and down and troubleshoot problems that happen with the vent. We follow the ventilator tubing circuit, from the patient down to the machine, and what happens with this kind of interaction is that we're able to reduce hospital days for these medically fragile patients by 85%.
Unbelievable.
It's amazing. We're able to reduce emergency visits by 80%. And the sort of the secret sauce, what really makes this work is having a skilled clinician immediately available 24/7 through the video. And because it's so easy to use the video, the clinicians can just hop on it, make a diagnosis. It only takes a few minutes sometimes to do this. So the clinicians are willing to do it because it's a lot easier than having these patients come into the office. It's a lot safer because you're doing it in the home and you don't run the risk of tubes being disconnected or that kind of problem when you have to transport them to the office. So patients 100% are happy with this kind of environment, this kind of telemedicine. The caregivers are happy. We think eventually the payers are going to be happy that they'll want to invest in these kinds of technologies. And in fact, we have conversations right now with a couple of important payers here in the state to begin to pay for teletechnologies for these medically fragile patients with an expectation that we'll be able to reduce their global costs. And I'm confident we'll be able to do that. The same ease of use and the same high quality video is important in one of our other projects, the Hawaii Stroke Network. The state gave a significant grant to the Queens Medical Center to develop a statewide telemedicine stroke triage or stroke management system. And we have several rural hospitals set up as spoke sites in Queens as the hub site where the stroke experts are. Now they are there virtually in the sense that they're not always actually in the hospital. They might be at home or out someplace on their cell phone or wherever, but within 2 or 3 minutes of a phone call from, let's say, Molokai Emergency Department, that's what that picture is of right there, the stroke specialist can be examining a patient and help the local emergency room physician make a decision about whether to use that clot buster medicine, the thrombolytic, to help dissolve the clot that has caused the acute stroke. Now that's critically important because you've got a window of about 3 hours ideally between the onset of symptoms to the time the clot busting medicine has been given to help with a stroke. And when you can get it within that 3 hour time frame, then patients do really well with that.
Hold that thought, because our guest, Dr. Dan Davis, clinical professor of informatics and internal medicine, is going to be right back in a minute. He's hot. We are not.
Aloha. I'm Nicole Horry for ThinkTech. For nearly half a century, the Hawaii Foreign Trade Zone No. 9 has brought the benefits of the Foreign Trade Zone program to Hawaii businesses and entrepreneurs. DBET, the Department of Business, Economic Development, and Tourism, operates Hawaii's Foreign Trade Zone program to encourage international business and economic development. The Foreign Trade Zone's mission is to increase the amount of international trading activity in Hawaii, thereby providing employment opportunities for the residents of our island state. For more information, see ftz9.org. I'm Nicole Hori. Mahalo.
You're watching Boritzer's Bio Briefings. My guest, Dan Davis, Queens Medical Hospital, clinical professor of informatics and internal medicine, and expert extraordinaire in telemedicine itself. We're talking about all the advances. Before we continue, I just want to ask some things that have been bothering me.
Sure.
Okay. When I sailed out of Honolulu in 1996 aboard my sailboat, I had a patient who was terminal, and he was getting all kinds of very advanced injections and so on, but he was afraid of overdosing on the trip, and we were out at sea, out of contact except by AT&T long lines shortwave radio. And that was only 96, and we were talking about 18 years ago, and none of this existed yet, because even satellite telephones were extremely expensive only for the very wealthy. Today things are a little different. Telemedicine has come a long way, even telesurgery. And when I'm thinking about the possibility of doing telesurgery from Hawaii to some remote place like New Tapuputapu in Tonga or Suva in Fiji and so on, just boggles the mind. But let me ask you something more personal. One of the things I asked you about, you come into your office, I know the procedure, I know the routine. Next step, one of the comforting things is when you check my reflexes on the bottom of my feet.
Yeah.
Now, how are you going to be able to do this with telemedicine?
Well, what we do right now,
Yes.
when we're checking reflexes, we actually train the bedside caregiver to do reflexes. And while you can't touch through the camera
That's right.
yet, and you can't smell through the camera yet, you can certainly see well. And so with our medically fragile patients in particular, for someone who has a neurologic problem that we're following serially, we'll actually teach the caregivers at the bedside to do some of these specialized maneuvers. What happens is that you can train a caregiver in a very narrow area to do certain tasks, and they can do them extremely well because we see them doing the tasks. We can coach them about how to do the tasks, and this virtual coaching is a very powerful learning tool for these folks. So yeah, we can do reflexes, and we've done reflexes. We can do a pretty thorough neurologic exam. In fact, that's what the docs are doing with the Telestroke program, the Hawaii Stroke Network. They're doing a neurologic exam through the video with the assistance of the caregivers at the bedside. In fact, that one picture is the team over at Molokai General, and they're there with their iCare exam cam on a pole cart, and that's when we first implemented it there, and they're very proud of that, and they've used it and really saved some lives with it.
Let me ask you something I know you're loath to discuss, and that is the political nature of medicine and some of the issues. I won't get into the Affordable Care Act because that's
how much time do we have?
No, we don't have enough time for that. But I do have a question.
Sure.
And one of the things is we know that Hawaii is underrated in terms of reimbursement costs for physicians on all kinds of various insurance schemes, governmental schemes, and so on. And that hinders our ability in Hawaii to get some of the top medical personnel to come and work here. So we have a shortage that is created by issues of money, not necessarily desire to work or patient load. Do you see telemedicine as part of the answer to the physician shortage, not only in Hawaii, but specifically on the neighbor islands, where the level of medicine is substandard, having felt it firsthand as a patient?
Yeah, I would say the access is substandard, not that the care is
right. No, I'm saying the amount
but yes, we will never, ever solve our access problems here in Hawaii unless we leverage telemedicine to its absolute fullest. And that's something that we can do now. And one of the messages that I've been trying to give the thought leaders in the state is just that notion that our access problems will never be solved by throwing money at it. We don't have enough money to throw at that problem, but we can solve the access problems with telemedicine. Again, the Hawaii Stroke Network is a great example of that. We're trying to build a long-term care telemedicine resource for 45 nursing homes in Hawaii. We have reached out with telemedicine to some of the private care homes, and that's worked out extremely well. So we can provide really good access, perhaps even better than what one can get in the doctor's office, considering all of the time and distance barriers with telemedicine. So yeah, access is real important. Another issue is, for example, if we don't have specialists immediately available, like dermatology for some of these outlying regions, we can work with dermatologists, both here and locally, as long as they're licensed in the state, to be available for telemedicine consultation. And perhaps two dermatologists could service, a large number of geographically dispersed sites through telemedicine.
As you were saying that, I just had an image of a dermatologist with a big nitrogen truck with a nozzle, and being on the iPhone, going from place to zapping your pre-cancerous cells on your face. I mean, it's just like, but I think that's almost 90% of the work of dermatologists probably in Hawaii is
liquid nitrogen.
Yes, yeah. But do you think that things like the physician's assistants and all these kind of sub-professional occupations can probably do a lot more to help physicians who have already telemedicine to actually effectuate treatment, diagnosis?
Yeah, no questions about that. Basically, the whole notion of telemedicine, it fits into this category of democratization of information. Fundamentally, what you're doing is you are developing tools to enable caregivers to exceed their conventional level of training. And the reason you're able to do that is because you have someone with extreme expertise looking over their shoulder, basically, coaching, the virtual coaching, to teach them how to do things, to monitor, to make sure that they're doing their procedures properly, to help them make decisions that they otherwise wouldn't be qualified to make. But it's a team approach, and the glue that holds the team together over distances is telemedicine.
I'm a big supporter of telemedicine. I want to tell you, and I think that Hawaii specifically as a focal point of telemedicine has a great future in all of the Pacific. I see us being the leadership entity,
we should be
the focus for Samoa, for Tonga, the Pacific Islands, Nauru, every remote place that doesn't have the resources to afford advanced physician services and have advanced problems, whether we talk about inflammatory disease, whether we talk about cancer, diabetes, and so on. Yeah. So what you're doing is really something extraordinary for such a small place in the middle of the Pacific to come up with the big ideas, but perhaps the ideas that can leverage few people that we have into extraordinary solutions, telemetry, and so on. One of the things I was surprised that has never taken off the ground is the fact of surgical telemetry. Telemetrical surgery that you can do from place to place with remote. Because when you have remote sites, and with global warming and all kinds of other issues over the next 20 to 30 years, there'll be more and more remote places that don't have the skill but need the services. So have you also given some thought to how to leverage telemedicine in a time where we're going to have an explosion of inflammatory disease, dementia, and all kinds of other chronic ailments? Because we don't have enough nursing home beds to do that.
I think the same rules apply to those kinds of conditions as apply to the medically fragile and some of those that we're having, that we're working with right now. It's basically using the technology to overcome these distance and time barriers. When there are, let's take an example of a patient with a progressive dementia with behavioral problems. That's extremely taxing to the family or the caregivers. And it takes a certain amount of judgment about what medicines and how the dosing and that kind of thing. And sometimes, ideally, these things need to be managed fairly frequently. You know, doses change every few days. You can't bring that patient into the doctor's office for a whole variety of reasons. And you can't bring them in every 3 days for that kind of dosage change. But, for example, in managing behavioral problems with dementia, telemedicine lends itself extremely well for that kind of treatment.
We're going to have to leave it right here. I did want to get into the whole thing, but I'll need it for a secondary session for sure. One of the issues I want to do, how do you get past the touch problems? And you hinted at it. Maybe there'll be some sensors and feedback loops and so on. And the other thing is really, how do you deliver mental health services via distance?
Happy to talk about that in the future.
So we'll talk about it again. I really want to thank all of you for watching today, and specifically my guest, Dr. Dan Davis, expert extraordinaire in telemedicine, enlightening us. We've just touched the surface. And we're going to get back to it next time. We hope to have you back again. Thank you so much.
Enjoyed it, Rafi.
You've been watching Boritzer's Bio Briefings. Until next time, remember, you're hot, we're not.